Okay. We are looking at chapter 12, fundamentals. And we just finished the circulatory system, or the fluid movement. So many of the approaches from the lymphatic adaptation are going to show up again as we get into this connective tissue idea. And again, there's a lot of confusion around this on what's myofascial release and where did it come from, and how does it fit into the broader scheme of manual therapy, and massage is manual therapy, and it goes round and round and round. It can be isolated out to address a particular area, just like fluid movement can. I mean, you can switch to fluid movement on a swollen ankle. Or it can just be an application that is incorporated into the general massage, because the connective tissue is a huge part of our structure, and we are sort of put together in layers that need to be able to slide. And so I refer you back to the videos that I recommended in your Essential Sciences, Gil Headley. He has done a really good job over the years with this idea of dissecting in layers. And so the skin superficial fascia, the deep fascia, the way the deep fascia surrounds functional muscle groups and creates separations from one functional group to the other, so that the veins and arteries and major lymph vessels and nerves can run through there. And they got a little trail to follow. So he oftentimes will think of us as an onion, the layers of an onion. So go take an onion apart and see, if you look really close when you take an onion apart, each time you peel off an area, they're connecting fibers from one layer of the onion to another. And then somehow or another, all the fluid movement vessels and the nerves have to perforate around through there, so that there's coordination and nutrition and waste removal throughout the entire body and all of the body tissues. So my suggestion is that general massage is going to assess for whether or not there is some connective tissue changes that might be easily addressed using just an adaptive approach to therapeutic massage. But it has separated itself out into a specific system, and you can go and learn connective tissue and myofascial approaches. Recent research does not support that we are breaking down adhesion. Possibly what is happening on a more mechanical level is that we're smearing out the WD-40, i.e. Hyralon, the slippery stuff, and temporarily changing the pliability of the connective tissues and the fascial wrappings. So let's see what we can do with this. So last time I had not turned my phone off, and that was Laura calling. And I have learned over the years that when Laura calls, you answer. That's my daughter. So now I got the phone on vibrate, so it's not going to interfere. But the birds are tweeting, so there you go. And my intent is for this to have the same kind of feel as it would have as I was in the classroom with you. Okay, here it is, connective tissue approaches. Modify massage application to target the connective tissues of the body. Now, connective tissues are huge. There are a lot of different kinds. So we're mostly thinking about the sponge-like superficial fascia, and um, we certainly can, with a mimic normal and biological plausibility, support that sliding. What we do below that, I don't know. I do know that this tissue is influenced by the autonomic nervous system. It does get denser under sympathetic, parasympathetic, sympathetic autonomic nervous system response, because it is protective then if the structure is more dense. Things, you know, blows and stuff can bounce off us, because remember, that's the fight or flight fear. And then it has a tendency to become more pliable, more fluid, viscous, when parasympathetic functions are dominating. But it also gets more viscous when we move around and stretch and go about daily activities, and it stiffens up. That's like a colloid does. It stiffens up if there is no movement, no mechanical force, or heat or whatever introduced into the tissue. So, and then it's highly, highly, highly embedded with nerves, sensory in particular, but also some motor. This stuff can contract on its own a little bit. There's little balls of muscle fibers in there called myofibroblasts. And there's been a ton of research in recent years, and there are organizations that are specifically related to fascial research. And so again, I think it's worth knowing all that, and I certainly believe that it's important to know how to adapt. I think just helping this tissue be as slippery and as pliable as it should be to support normal function is, I think that we can do that. It's logical. The other thing is, though, that we have to remember the balance between stability and mobility. And a lot of the issues in connective tissue approaches is that it's not necessarily dense and short and stiff. It's actually too pliable. And you've got laxity inherent, and there are actually connective tissue disorders. Marfan syndrome is an example of one that can be quite serious because of the weakness inherent in the arteries. So we tend to want to, think about everything being stiff and needing to be softened, and everything being short needing to be lengthened, but that's not the case. And people that have laxity, inherent laxity, their muscles themselves oftentimes have to be contracting isometrically to provide joint stability. And their chronic pain, chronic somatic pain is quite common with an underlying joint laxity. And this can occur also in an isolated area, like if somebody has sprained their ankle multiple times, and it's just not stable. You know, it's common for the calf to be quite stiff. And if somebody has done too much yoga and they're too flexible, you can see a secondary response of trying to firm back up again. So I'm back to the too much of a good thing becomes a bad thing with this. So do look back at chapters 5 and 6 and do some research on your own with this. There's quite a lot on PubMed. So this is talking about a lot of what I just kind of rambled through. And I try to think of this stuff as fluid and fibers. And the fluid is like Jello, which is a colloid. All right. So, but what I do so that watery material that has proteins and stuff embedded in it so that it has some form. And then fibers. You've got collagen and elastin and various reticular fibers and little filaments that connect one layer to the other. And I think we do a little less with the fibers. Inflammation will cause a proliferation of collagen fibers. Injury will, that's what a scar is. So if it's actually fibrosis and it's become fibrotic, I am not sure that we can really do much around that other than to normalize the tissue, like around a scar, other than to normalize the tissues around it. And I think we can temporarily support some sliding and some pliability. So, but the focus of scar tissue is to hold something together. And I think what's missed sometimes is getting to mechanical forces introduced into scar tissue early so that it doesn't, because it's sticky and it has a tendency to adhere down, and then you get kind of a stiff, stuck, non-functional scar. I think I've mentioned before that I had open heart surgery, and that is a big hole. And it goes down through not a lot of muscle tissue, but it does go down through the skin, superficial fascia. Some muscle opens up the sternum. And so then when they sew you back up, there's a muscle on the inside, muscle structure on the inside of the thoracic cage. So they have to, and there's fascia, there's peritoneum or pleura that, you know, if they're doing it right, they're going to sew each of these layers together separately. I don't know if that happens. A plastic surgeon may do that, but a lot of times they'll just take a hunk of this tissue and they'll glue it or staple it, right? So that the tissues are approximated. Now the surgeon I had, I think, did at least some of the stitching together of the individual layers. I don't have a ton of stiffness in my thorax. I do along my back, and I think that has more to do with some damage that happened when the rib cage was opened up. So I'm kind of stiff along the attachments of the ribs to the vertebrae back there. But the scar itself in the front, as soon as I was aware, I started loading that tissue. I started moving it around and being aware of infection, but I got on it right away. In addition, I had, where they harvested a vein in my leg, I had some pretty good sized scars there, and they are pretty good. And I think that part of it was I was fairly young. I was in my 50s when this happened. Um, but I also think that I got right on it because I had the information on how to deal with that. So, but once the scar is matured and it's older, then it might be harder to get any kind of persistent change in it. So always stop and read your little um, your little boxes here. And a lot of what I just talked about is described here, and the dysfunctions as well. So a connective tissue type approach has been around a long time. Ida Rolf probably is the one that people will think of. It got separated out as a distinct manual therapy, not by Ida Rolf, but by her followers. And there are educators still providing continuing education that actually learned under Ida Rolf. And so if you put the ideas together here with other systems, these are some directions that you want to move the skin and superficial fascia. And lots of times we spend too much time going up and down. We're thinking too much about muscle. And we should probably think more about the surrounding tissues and making sure that the skin superficial fascia interface is very much like a wetsuit that we put on, highly innervated, very sensory, but also has motor response. And then the tougher tarp-like fascia that surrounds muscles and creates deep fascial separations and planes. The lumbar dorsal fascia back here. There's been a lot of individual research on that, also related to a breathing function. So, you know, we're starting to get a circle here. So this tells you pretty much what you do to modify the massage just a little bit. And what we're doing is we've got to now assess for ease and bind. And in the classroom, we demonstrated that when we were looking at the lymphatic movement, the movement of the superficial fascia. And we kept moving the tissue to bind with the concept in our head that at that stop point, the lymphatic collectors, the little microscopic capillaries that were open-ended like a root, that the little connector, the little fiber that connected that to the superficial fascia as well as the deep fascia underneath it, that we were pretending that we were opening that up so that the fluid would move into it. When we are thinking more of a like myofascial work, then it's a lot of it is done in that same tissue level with that same depth of pressure. Direction is less important. The speed is slow. We want a lot of drag. So the lubricant, just like with the lymphatic work, the lubricant is diminished, and usually there isn't any. So we want to be able to really tug on that skin, and we take it to the bind. We move it back and forth from its easiest to its stop point, and then we apply a load out, not down, but a load out to try to move it just beyond bind there. That's the general premise. So here is what we would do specifically if we had densification, which is thick jello. And this is also going to, these methods are also going to affect what's called fascial tone. And those are those little circles of muscle that keep the fascia taut. Think of a trampoline. Now, deep transverse friction, and we talked about this a little bit in the implement assisted thing about the scraping can cause inflammation. That's what deep transverse friction does. And the theory behind that is that these smaller areas where there's a collection of fibers that are causing restriction and movement, if we reintroduce acute inflammation, that might remodel and it might be more functional with that. So we re-injure it for it to heal better is basically what it amounts to. And that's usually done in a much more pinpointed way. Now, here is some direct work on a scar that you know, the assessment part of is it, will it lift and will it slide? Will it lift and will it slide? That's pretty much the assessment. So when we're doing the general massage and we're part of it, might be a skin roll, we learned that, or a kneading action. That's where we're assessing, will it lift? And then when we're using, loading it with tension stress, when we're gliding, if you don't have too much lubricant on there, you can move that tissue back and forth and to ease and bind, and you can see, you know, where the slip might have diminished. So this is using a shear application on the scar here, but this is the same things we would use as an intervention if our assessment shows that the tissue is just not sliding as well as it could. And that's not an adhesion, it's just not slippery underneath there. And this will increase the pliability. And then this is a pretty aggressive method here where we're really creating a trampoline right here, a sustained force apart. And this is the premise for most myofascial release type applications, to take the tissue to bind and then over that through bind. And then if you added, here this is in her arm, if you added some movement at the wrist, that will introduce another force. So there's multiple loading in there. So connective tissue we're always assessing with it. We're always trying to make sure that it's slippery and sliding and all of that. But these actual methods are intervention. Just like the circulatory stuff, the fluid movement we just got done talking about, these are interventions. We assess with general massage methods and then make a decision about whether or not focusing to a particular tissue function or physiological function could be beneficial. And if we decide that it is, then we do these things. So these are, people always want to get in there and do something about something. So what we're looking at here is trying to do something, but we don't do something until we have assessed to make sure that the tissue is pretty normal, which happens with the general massage. And then we can pick and choose these various interventions, like friction is an intervention. Moving tissue back and forth from ease to bind is an assessment, but it is also, if you increase the intensity just a little bit and slow it down, an intervention. Just like we saw with the scar tissue. Let's see if I can get back to that. When we were working on that, each of those is an intervention. So if we were to intervene early, like I described with a scar, these would be the things that I would do on a fresh scar, but much, much gentler, and to keep it moving. All right. And we want to be cautious while the scar is fresh so that there's no inflammation. So we just stay further away from the scar. So this connective tissue protocol, this is going to give you some visuals on how we would narrow the massage application down. So this tissue here is soft. It's not like we are pulling it apart. We're not trying to pull this apart. We got it where there's space in there. And then we take it to the end range with it, where if we go much further, we might actually get a tear or something in there. Now that's probably not going to happen, but that's what we have in our mindset. And then you can add to this while you've got tissue held in ease. If you have a person move underneath it, there's encouraging slip and slide, and same here. Now we talked about suction cups back when we were looking at using tools. The suction cup is pulling tissue up and it will create bind. So ease and bind. And this in between should feel taut, like you have stretched plastic wrap around a container. And then that's where those two ends of full ease and full bind, that's the therapeutic range where the tissues are going to respond. So we can do that same thing on a very isolated level. And this can become an assessment. We just stretch the tissue a little bit. Now, that's a similar method that they use for lymphatic drain. So these things start to roll on top of each other. Here's another aspect of that. Hold this down still here and then use a glide, no lubricant, and it will push that superficial tissue primarily. It'll drag that forward. And then if we added movement here at the joint, now we've got some combined loading, and sometimes they'll even put a name on that, like active release technique. So here we're lifting, which is the assessment, but then slowed down with a little bit more intensity becomes the intervention. And then we're adding some shear load on this. And then same thing, the lifting is the assessment. And then if we feel as if this is, especially when we compare it to a similar body area, this side to this side, if we find that something is a little stiffer or doesn't lift as much or is thicker when we try to lift it, we may want to introduce some loading into that tissue. So we've got a lift with a bend here. Here's a bigger area, this would be targeted to separate compartments. So this is posterior. This is the posterior compartment of the thigh, primarily a knee flexor, but also a hip extensor. And the way, this is Luke, the way he has got his hand position, he's got that whole functional compartment that's wrapped in deep fascia pulled. The fingers are put into the separation between the posterior compartment and the lateral compartment. And so then there's a lift and a pull, and then a back and forth shearing that goes with that. Kneading, slow, deliberate, big, no lubricant, no slip, is like twisting a hanger. That's not the bed, but you know how if you move something back and forth like that, it heats up and becomes more pliable. Here is a fixed position at the head, held at bind, and then a force applied through the shoulder so that the tissue in between here is taut. Same here on the wrist. And so another approach to this is that you assess to see if there's thickness, density, and then you pin that area down with the joint position so that it's at ease here. And then that's held, and then you bring the arm out, so that is going to create a tension load precisely into the area that you've got pinned down. Here's another example of that. Luke has got the tissue crowded in ease, and then it's held down by the forearm, and then the client in this instance is going to move the tissue so that it comes apart. And so this is more active. In a therapeutic outcome, the more involved, the more active the client is, the more likely the nervous system is going to respond, and the more awareness they have. So the premise is ease and bind, ease and bind. And I'm going to continue with funds are quite similar, and you can assess these through palpation. Or, if you lightly drag your fingers on the skin, often the area where these tender / trigger points is at has a little bit of sweat there, and it'll feel sticky. And we'll show you how to do that in the classroom. So it was these idea of these points have been around forever. This is not new. And there's a huge correlation between traditional acupuncture points, where the trigger points are located, where the meridians are at, where other cultural approaches have targeted areas and points. And we discussed this idea of a tender trigger point in chapter 9 in the Essential Sciences book. And each muscle that we have described there as you learn it, there's an example of where the trigger area is often located, and then the symptom that can be perpetuated through that. So research is back and forth on this. My personal opinion is that it's a good theoretical model to work with. Even if what we think it is, like a knot or something, it's not a knot kind of a thing. A knot, a palpable knot is either densification of the connective tissue in an area that may or may not be fibrotic. Often these are just muscle layers that people, one layer on top of another, so that you get a sense of a bump, and people aren't palpating effectively to know that. It could also be an area of contracture in the actual muscle fiber structure that for some reason hasn't totally let go. The most common intervention you will find for these spots is inhibitory pressure. So you press on the spot until the sensation is stimulated, and that sensation needs to be familiar. It needs to be what the client is experiencing. Then you can do a number of things. You can go back and look at chapter 10 in the textbook, fundamentals, and do positional release. You can move the tissue in the area in and out of bind. You can hold it down and move it back and forth. You can hold the area down and have the person move it back and forth. You can lift it up and have the person move to slide the tissue underneath it. There's a lot of interventions here. Now, a trigger point is not a method. It's a condition. It's a finding. So if somebody says, I'm going to do trigger point on you, I don't know what that means. I may assess for these tender points that cause a familiar sensation, and then I might think about a various intervention with that. And Dr. Leon Chadow, my teacher, mentor, and friend, was the expert here in this, and I learned so much from him on this. And so the information here, a lot of it goes back to what he taught me. So here, there are some theories around how these trigger, tender, pointy things occur. And maybe, maybe not. It's all theory. It's been difficult to nail down. This is biologically plausible. And then here's what I do a lot of times with this, other than assessing for with the drag palpation and or identifying with the various pressure levels I use during the general massage. I will then, I might find something where the person goes, oh yeah, that's the thing, that's the spot. But I also will show them this chart. And this is actually out of one of Dr. Chadow's books, but it's modified from Janet Travell, who had sorted this out. And like Ida Rolf, was ahead of her time, and was postulating about these things before there was the science to thoroughly investigate. One of the things they found about these tender points is that the interstitial fluid around it, most of these are located where there's a neurovascular bundle perforating out from the deeper vessels out to the more surface. And there's a lot of, so there would be tissue fluid around that, i.e. what we looked at with the lymphatic system. And if the exchange isn't very good, one of the things that happens is, and this is part of a problem with lymphedema, the tissue becomes more acidic. and or the tissue fluid becomes more acidic, and the nerves particular don't like an acid environment. And think about what happens if you have vinegar and it gets on a cut. So that could be the perpetuating factor here that's causing some sort of feedback loop that becomes habituated, and the central sensitization. And so hopefully you're starting to see that those research chapters are coming into play here. So I'll give them this chart and I say, can you find your spot? And pay attention to the red. Can you find the spot where it bothers you, the red thing? And they might be able to do that. This one's common here on the pectoralis muscles or area. They'll think there's something going on with their elbow. And then with serratus anterior, there's that perpetuating horrid spot behind the shoulder blade, but the issue is in the serratus muscle more anterior. Sometimes these referred pain patterns follow dermatome, but not always. So that's part of the conundrum on trying to figure out how to analyze what's going on. And if you actually have a nerve impingement, I'm trying to find a picture here that would have that. So here, on the posterior torso here, you could have an actual impingement of a spinal nerve trying to get through the lumbar vertebrae. And it could be that, and not necessarily a tender trigger point area. So the referral patterns can cross over to different causal factors. So if the person says, oh, yeah, that's it right there, then I'll do another assessment. I will use a more concentrated pressure in that area where that tender point commonly is located. There's two spots right here on this one, and see if I can reproduce the sensation. If I can, if that pressure can, then maybe something like moving it in and out of ease and bind, or inhibitory pressure, or something like that might interfere enough with that neural loop that has been created that it'll extinguish that or make it not so hypersensitive. So this is a common one right here with stuff that happens in it's scalene-ish area, and the levator scapula area and the upper trapezius area, all of this in here that refers into these patterns. But it also can be impingement of the brachial plexus that does this, or the cervical plexus. So this, intervening as if it was a trigger point can maybe give some temporary relief there. But if it keeps coming back and coming back and coming back, you have to look deeper. So that's how I do this, is I just say, okay, look at this, and you tell me which one is the one that's going on with you. And So, I mean, there's some other things here. It gets sweat, the skin above the trigger point area gets a little sweaty. We've got these uh, areas where the mobility might be diminished. There might even be a little localized swelling right there. These areas can become fibrotic. And so that sometimes you'll use some deep transverse friction in the area over top of a trigger point if you think it's fibrotic. So this goes through a sequence of how you would assess for and identify, and then which ones you would choose. So with to address, and just like everything, less is more on this. So the ones that are most painful and reproduce the symptom the person's experience, that are closest into the body, that are in the short tissue. Remember the cave and hill. So in the short, in the belly of the muscle as opposed to the ends. And then you look around the area a little bit and see if there's, it's called a latent trigger point. It's not as pronounced, but it will also trigger that sensation. So this sort of thing often is combined in what's called neuromuscular therapy. That so you can have myofascial stuff that's inclusive of the trigger point, or you can have trigger points pulled out and called neuromuscular therapy. And you know, that again has separated itself out to be a unique system, and there are continuing education providers going around, and they're teaching neuromuscular therapy. And there is a specific certification, not an education, a certification for trigger points. It's not been as consistent or as successful as the National Certification Board for Massage Therapy, or LANA for lymphatic drainage, but it's there. And so if you are really wanting the credentialing that goes with this, then the credentialing comes from that association, not from the educator. So here's some examples of that. And these are all the ischemic pressure. This is the least desirable here because the thumb just won't stand up to that. This is better. See, it's the same spot. And I'm using both hands together to kind of create my vector, my angle, to get to the trigger point area. A lot of these are in the local muscles, not in the global ones. They're in the synergist, not in the prime mover. And they'll act up on eccentric action more so than concentric action. So this is even better. Sometimes you can use a squeeze action, and then you can introduce movement with it. Okay, so now we're moving away from adaptive massage methodology adapted to target a particular area, and we're going to get into some cultural systems. Now, they still push and pull. And a lot of the areas where the push and pull is the same thing we just talked about. Like I had mentioned, there's a huge correlation, over 90%, between common trigger points that have been mapped and acupuncture points. So, but this idea of points and lines, it's a theory structure. It's a way of thinking in and of itself. So that's what we're going to explore in the next clip. Okay, so either this has clarified it or it's confused you. I am often confused about all this myself.